Good day, everyone. We are Group 5 and I am with Adjaneda, Bugay, Dimakulangan, Sampang, and I am Valdemar. And we are here to report immunologic disorder. And for the first topic, may I call on Mr. Dimakulangan?
For the points of discussion in our group, we will tackle disorders of neutrophil, monocyte and macrophage disorders, leukocyte integrins disease, primary immunodeficiency disorder, secondary immunodeficiency disorder, and lastly, autoimmune lymphoproliferative disorder. What I will be discussing is the disorders of neutrophil. There are three types of neutrophil disorders. The first is non-infectious neutrophil-mediated inflammatory disease. Number 2 is abnormal neutrophil function. And number 3 is congenital neutrophil abnormalities. So let us have a recall. What is neutrophil? Neutrophil is also known as segmenters, which is the term mostly used inside the laboratory setting. It provides the major means of defense against bacterial and fungal infections. It has an amoeboid-like motility. The structure is a gelatin-like that goes through spaces in the RBCs. But what we are going to discuss for today is the problem that they can also be destructive to the human's body tissues. Kapag ang isang tao ay nagkakameron ng problems when it comes to our specific granules or secondary granules, which is our neutrophils, along with eosinophils and basophils, na kung saan ito rin ay part ng subgroup of our WBC, ay isang malaking problema. Lalo na ang neutrophils natin ay may malaking part sa pag-fight off ng ating mga bacteria and other foreign substances. Please, back po ng slide. Yan. The first type of our neutrophil disorder is non-infectious neutrophil-mediated inflammatory disease. This is the process where it occurs when phagocyte attempts to engulf particles that are too large. Alam naman po natin na ang ating phagocyte is a type of cell that only engulfs small cells and particles. And the main problem in here is that it engulfs too large from the cells and other particles, kung saan nag-go over yung pag-absorb niya at pag-engulf na nagre-resulta ng pag-release ng oxygen radicals and granule contents hanggang sa nag-escape ito sa surrounding tissues na nagkokos ng damage. This is often observed to dust inhalation and smoking. Mostly sa smoking po, ito ay nakukuha pag sa mga nagve-vape. Kapag sobra na po yung kanilang nai-inhale sa nicotine, yan po ang nagiging resulta, non-infectious neutrophil-mediated inflammatory disease. And persistent din po siya sa mga infections such as cystic fibrosis. Examples of this is rheumatoid arthritis, multiple sclerosis, and Graves' disease. Ito po yung mga disease na talagang sobrang malala na po pag yung hindi na po makontrol nung phagocyte yung kanilang pag-engulf at nagkokos na po ng too much damage, hindi lang po sa tissue, kundi sa mismong organ na din po. Next slide, please. The signs and symptoms and injury that is caused by mediated neutrophils. This is the mostly na nakikita po natin kaagad pag naapektuhan ng isang tao once na too much consume of inhalation of dust and nicotine. This is based on the book by our Turgeon. Next slide po, please. Here are some abnormal neutrophil function. The first is defect of neutrophils. Patients with quantitative or qualitative defects have a high rate of infection. Ito yung neutrophils natin ay hindi nakaka-respond agad sa mga bacteria o foreign substances. Medyo mabagal yung kanya nagiging movement sa pag-respond due to some infections. Kaya yung individual natin hindi baga alert yung ating neutrophil when it comes to pagtitake ng action, lalong-lalo na pag naging presented ang foreign substances sa katawan natin. Second is decrease of neutrophils, or also known as neutropenia. This has severe defects in neutrophils function and frequently have recurrent systemic bacterial infections. Ang example po nito ay pneumonia. Usually kasi ang adults ay nagka-count about 1,500 neutrophils per microliter of blood. Or pag nag-less ito, nagkokos na siya ng neutropenia kapag below 500 per microliter. Kung saan nagkakameron na to ng severe case. In severe cases, kahit yung bacteria ay normally present in the mouth, skin, and gut that causes serious infections. Yun po yung nagiging cause ng neutropenia. Third is leukocyte mobility, which is impaired in some diseases. This is the defects that affects how white blood cells respond and travel to the site of a wound or infection. Most likely parang mabagal lang yung kanyang pagkaka-respond, pero papunta na siya, pero hindi lang agad-agad na iibsan yung kailangan nilang role na i-take action dun sa wound or infection. Next slide. Leukocyte immobility, also known as defective locomotion. It can be seen with patients receiving steroids and in those with lazy leukocyte syndrome. This is also known as leukocyte extravasation, which varies in the vessels that contains different shear of forces of the ongoing blood flow. Yung sa ating blood flow, kokonti lang yung neutrophils na gumagalaw sa katawan ng isang tao, kaya hindi full force yung pagbibigay once na needed na siyang mag-take up ng action pag merong mga foreign substances and bacteria. Lastly is the defect in cellular response. Chemotaxis defect is an important step in phagocytosis, which I will discuss further po mamaya. Na-mention ko rin naman earlier kung na ang phagocytosis naman natin, siya yung isa sa problem ng neutrophils kasi yung ating phagocytosis ay siya yung unang nagsisilbing respondent ng neutrophils natin pag kinakailangan ng mga kalabanin ang mga foreign substances at bacteria pag pumasok sa ating katawan. And usually, pag nagkakameron ng defect in our cellular response, ay nagkakameron ng mga severe cases like diabetes mellitus, Chiari-Higashi anomaly, sepsis, high level of antibody, immunoglobulin E, and Job syndrome. Next. Number 3 is congenital neutrophil abnormalities. Only a few patients encounter these abnormalities in the neutrophil structure and function. Pag chinek po ito sa ating microscope, usually yung neutrophils natin ay hindi po okay yung kanyang pagkaka-present for the structure and its structure pag chinecheck po under the microscope, and mostly yung function niya pag tinetest po natin. Wala lang po akong mahanap na picture. Types of abnormalities involving congenital neutrophil, Chiari-Higashi syndrome, chronic granulomatous disease, complement receptor 3 deficiency, myeloperoxidase deficiency, and specific granule deficiency. Next slide. Chiari-Higashi syndrome. This is the chronic granulomatosis. This represents a qualitative disorders of neutrophils. It is a rare familiar disorder inherited as autosomal recessive trait. Autosomal means, pag sinabi nating autosomal recessive, ito ay inai-inherit from a child from a parent. And na-express ng abnormal agglutination, nag-e-express ng abnormal agglutination sa ating neutrophils. Neutrophils having giant granules displayed impaired chemotaxis and delayed killing of ingested bacteria. Nakikita po natin dito sa picture na hindi po ang nagiging effect po ng Chiari, parang siya po yung agad na hindi nakaka-respond sa ating mga bacteria, and yung bacteria po natin nag-i-inhibit po siya dun sa place ng ating katawan. And yan po yung nagiging presented na itsura niya po. masyado pong nagiging neutral yung staining ng kanyang specific granules, and yung kanya pong cytoplasmic lysosomes ay large inclusions, at yung kanya pong nucleus ay sobra pong nagmatured at segmented. Next slide, please. Chronic granulomatous disease. This represents a qualitative disorders of neutrophils. It is a rare familiar disorder inherited as an autosomal recessive trait. Katulad po ng sinabi ko kanina, nai-inherit din po ulit ito sa isang magulang ng isang bata. It was observed in the presence of normal elevated leukocyte counts that the neutrophil in vitro ingested and destroyed only ang streptococci. Yung streptococci kasi natin, siya yung infection in our blood. So, yun yung na-eliminate dito sa disease na to, yung streptococci natin sa blood na-eliminate agad. Pagdating naman doon sa staphylococci, hindi siya kagad na-eliminate. Yung staphylococci kasi natin, siya yung tinatawag natin na pus formation. Yung pus natin, siya yung thick fluid na dead tissue na napoproduce pag nagfa-fight off ang ating infection sa katawan, especially pag cause ng bacteria. So, kunwari, si neutrophil, nag-react siya dun sa bacteria, nakakapag-produce siya ng staphylococci. And yung na-produce na staphylococci, hindi kagad yun na-eliminate, which is nag-i-inhibit sa ating katawan. Kaya dyan parang sa example ko, pag nakita nyo dyan sa picture ay meron na agad dalawang neutrophils na nagpe-present ng pus features sa loob, kaya na hindi agad siya na-eliminate, which is dapat kailangan ina-eliminate siya ng katawan natin. Yun yung nagiging chronic granulomatous disease natin sa katawan. Naiipon yung pus sa loob ng WBC. Next. Complement receptor 3. So, deficiency. So, ano naman yung ating complement receptor 3? Our complement receptor 3 is mainly expressed on macrophages, monocytes, granulocytes, and our NK cells. Ito yung nagpe-play ng role na kung saan yung cell-to-cell and cell matrix interaction. Ito yung nag-e-enable ng establishment of our leukocyte adherence sa endothelium natin, which this also facilitates the movement of our leukocytes through the endothelial intercellular junction. So yun, alam na natin ang role ng CR3. So CR3 facilitates the movement of our leukocytes. And the main problem in here in our complement receptor 3 deficiency is that there is a deficiency in our leukocyte adhesion, which is associated with marked abnormalities of adherence-related function. So pag once na nagka-problem dun sa leukocyte adhesion deficiency natin, ay kaagad na maiisip natin ay complement receptor 3 deficiency. Kasi yung complement receptor 3 natin, siya yung nagpa-facilitate na movement ng ating leukocyte adhesion sa ating endothelial intercellular junction. Next slide. And lastly, our myeloperoxidase deficiency. So, ano po ang ating myeloperoxidase? Ang myeloperoxidase po natin, ang kanyang first thing na ginagawa sa ating neutrophil, siya po yung nire-release ng ating neutrophil to fight off bacteria. This has also a strong capability or activity to kill off a bacteria activity. And pag meron tayo ng problem sa myeloperoxidase deficiency, agad na yung maiisip natin na sino kaya magre-respond agad pag may problem ito? Ay yung ating neutrophil magkakameron ng problem. Hindi kaagad niya mareresolbahan yung mga bacteria or foreign substances na atake. And ang kanyang itsura, pag chinek sa microscope, gawa ng staining, kaya by pink to purple ang kanyang itsura. Pero ang kanya namang itsura talaga sa personal pag kinolek ay greenish color of pus. Persons with myeloperoxidase deficiency are generally healthy and do not have an increased frequency of infection, probably because of other biocidal mechanisms compensating for the deficiency. So, syempre, yung neutrophils natin, hindi, may other reacting factors din naman siya. Kaya, if ever man pumalya yung kanyang myeloperoxidase, ay hindi naman ganun ka-gravely ang makaka-affect sa ating katawan. So, pero kailangan pa din siyang i-monitor sa isang tao kasi hindi naman maganda na yung myeloperoxidase natin na first thing na nire-release ng ating neutrophil agad pag kailangan kalabanan ng phytobacteria ay hindi gagana. So for our next slide, Miss Bugay will present the next topic. Meron specific granule deficiency. Sorry. This is also an autosomal recessive disease. It is caused by a failure to synthesize specific granules and some contents of other granules during differentiation of neutrophils in the bone marrow. Patients with specific granule deficiency have recurrent severe bacterial infections of the skin, deep tissues with depressed inflammatory response. Usually, ang problem naman natin dito is ang ating granules na hindi niya kagad na di-differentiate yung neutrophils sa mga other contents na pumapasok, lalo na pag yung neutrophils kinalaban niya yung mga foreign substances and other bacteria, hindi niya kagad na detect yun. Next slide.
So I'm going to discuss the monocyte and macrophages disorders. Next slide. Monocyte and macrophages have been shown to be abnormal in a variety of diseases. The table shows the primary and secondary abnormalities of monocyte and macrophage function. The defect in phagocyte killing seen in patients with CGD or chronic granulomatous disease results in the formation of subcutaneous abscess in liver, lungs, spleen, and lymph nodes. While the cancer patients with defective monocyte cytotoxicity because of the tumors that have the ability to release factors that suppress the generation of toxic oxygen metabolites by macrophages, while the defective release of macrophages activating factors and depressed migration is commonly seen with patients with acquired immunodeficiency syndrome and newborn infants. In addition, the newborn's macrophages may not respond effectively to the infection because of the impaired production of the macrophage activator, which is the interferon gamma. So the interferon gamma is a cytokine critical to both innate and adaptive immunity, and the primary function is to activate macrophages and to stimulate the natural killing cells and neutrophils. And last, the impaired phagocytosis is seen in patients with congenital deficiency of CD11 to 18, monocytic leukemia, and systemic lupus erythematosus. Next slide. The monocyte and macrophages disorder manifests as lipid storage disease. So this includes the rare autosomal recessive disorders. Since the macrophages are particularly prone to accumulate undegraded lipid products. So this is the two types of disorders, the Gaucher's disease and the Niemann-Pick disease. Next slide, please. So the Gaucher's disease is an inherited disease and most frequently affects children. This is caused by the disturbance of cellular lipid metabolism. It represents a deficiency in B-glucocerebrosidase, the enzyme that normally splits glucose from its parent sphingolipid and glucosylceramide. The prognosis it varies with mild diseases. The patient may live a normal life, but with the severe cases, the patient may die prematurely. The Gaucher cells is rarely found in the circulating blood. The cell is large with 1 to 3 eccentric nuclei and characteristically wrinkled cytoplasm. It is often found in the bone marrow, spleen, and other organs of the mononuclear phagocyte system. Next slide. And last is the Niemann-Pick disease, also a inherited abnormality of lipid metabolism similarly to the Gaucher's disease. It affects infants and children with an average of life expectancy of 5 years. It is a rare autosomal recessive deficiency of the enzyme sphingomyelinase characterized by massive accumulation of sphingomyelin in the mononuclear phagocytes. The peak cell or also this cell is similarly to the Gaucher cells, but the difference is its cytoplasm is foamy in appearance. Next po.
Good day, everyone. My topic is all about disease states involving leukocyte integrin. So, first and first and foremost, what is leukocyte integrins? Leukocyte integrins involve cellular adhesion receptor that mediates cell to cell and cell to extracellular matrix. So, typically, it is cellular adhesion. So when we say adhesion, it means it forms molecules between the or different surface inside our body and cause them to stick together. Next slide, please. So we have what we call leukocyte adhesion deficiency or simply LAD. This this ultimately lead to recurrent and often fatal bacterial and infection. And according to Turgeon, this is very rare condition is mutation in the gene or chromosomes. 300 cases have been diagnosed worldwide. It is disorder in which leukocytes are unable to migrate to the site of the infection due to the defect adhesion of protein. I repeat, unable to migrate to the site of infection. So meaning to say, yung trabaho ng leukocyte natin to fight infection and other disease ay wala. So meaning hindi nagpapangsyon. Next slide please. So we have two types of blood based on the genotypes and phenotypes. So LAD1 can affect people of racial group. These are the patients who have deficiency of the beta-2 integrin subunit or simply CD18. So, pag-usapan muna natin, ano nga ba yung beta-2 integrin? So, si beta-2 integrin is a complex leukocyte-specific adhesion molecules. I repeat, it is complex leukocyte-specific adhesion molecules wherein it is essential for our leukocyte. Next slide, please. And for the type 2, reportedly only in people from the Middle East and Brazil. This is the failure to convert GDP mannose to fructose. So, meaning to say, there is a problem in our enzyme here. So, deficit ang ating fructose. So, ano ng first thing, ano bang ano ng ating fructose is a sugar which napaka-importante nito sa ating katawan bilang source ng ating energy. So, what happened here is it can lead to immunodeficiency. Kumbaga, nagiging mahina isang patient or wala tayong panlaban sa sakit. As well as it can affect, I repeat, it can affect our psychomotor retardation. So, it can cause visible slowing of physical and emotional reaction, including speech. So, for our phenotypes, it is simply severe, moderate, novel, or variant. Next slide, please. So this is the example of our ladder and as well as its manifestation. So patient have a history of delay of separation of umbilical cord, gingivitis. So as we can see here in the figure, the healthy gum and the gum with the disease. Third is recurrent and persistent bacterial or fungal skin infection. See here, as we can see here in the second image, impaired wound healing. The third image, then fourth is lack of pus formation has also been noted. And last is patient develop severe life-threatening infection. So, sabi nga rin dito, although their neutrophil counts are usually elevated, kumbaga hindi pa rin nagbabari. Next slide, please. So, on the other hand, these are the characteristic of patient with blood type 2. So, first here is the short stature. Ano nga bang short stature? It is simply does not grow as tall as other people with the same gender and age. So, may kaklasify rin natin ito na ang isang patient or isang person na yung what I mean yung height niya here is below the third percentile. Kumbaga, hindi wala sa average. Upon his age ko na 18, yung average height nung taong yon ay hindi sakto doon. Then we have what we call limb malformation. So ano naman tong limb malformation? Itong limb malformation is a simply deficiency are missing or incomplete in the limbs at the birth. And lastly, severe development delay. Next slide, please. So, before I end this, let's remember this. So, adhesion defect can cause two common drugs. So, hindi lang pala inside our body. So, pwede rin maka-epekto ang ating mga iniinom na gamot. Sabi nga dito, epinephrine and corticosteroids. Second is both of it demarginate neutrophils from the peripheral vasculature, although mechanism is not understood. So, meaning to say, yung trabaho ng neutrophil natin as a first-line defense to phagocytize, killing, and digest bacteria, ay hindi niya na gagawan. Kasi nga bakit? May pumipigil eh. May umaano sa kanila, movement away para hindi makapunta sa ating peripheral vasculature. Ano naman yung peripheral vasculature? Ating peripheral vasculature ay ating mga veins and arteries. So last is epinephrine acts by causing endothelial cell to release cyclic and adenosine monophosphate, which turn to interrupt adherence. So according to the study, ito daw cyclic adenosine monophosphate ay can trigger apoptosis or yung cell death, and it induce adhesion of hematopoietic cell. So that's all, and for the next topic will be discussed by Ms. Calderon.
For the next topic, we will be discussing primary immunodeficiency disorders. Next. Back pala. Primary immunodeficiency disorders, these are rare genetic disorders of the innate and adaptive immune system, which means that there have been identified gene mutations that cause varying degrees of impairment in immune cell differentiation and/or function. Diseases associated with a primary defect in the immune response is comprised of about 40% T-cell disorders, 50% B-cell disorders, 6% phagocytic abnormalities, and 4% complement alterations. 75% of primary immunodeficiency disorder is predominantly seen in children younger than 5 years. So if you may ask how these primary immunodeficiency disorders are being treated, it is by the use of gene therapy with hematopoietic stem cells, which is a therapeutic strategy for the treatment of several forms. Next is the the type of primary immunodeficiency disorder, which is the T-cell and combined immunodeficiency disorders. Next. 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 First is the DiGeorge syndrome. Its cause is this this T-cell deficiency is a congenital disorder that results in aplasia of the parathyroid and thymus glands due to defective embryogenesis of the endodermal derivation of the third and fourth pharyngeal pouches. In addition, a zinc deficiency in utero has been suggested as a cause of this process. For its signs and symptoms, it is present from the moment a fetus is born, and its initial manifestations can include hypocalcemic tetany, unusual phases, and congenital heart defects. Its immunologic manifestations are its peripheral lymphoid tissues appears to be normal except for the depletion of T cells in thymus-dependent zones. Lymphopenia is common in the circulating blood, but the concentration of lymphocytes may be normal in some cases. And also the concentrations of Ig in the blood are close, immunoglobulin in the blood are close to average. IgA levels may be lower and IgE levels may be higher. Next. Nasalov syndrome, or also known as cellular immunodeficiency with immunoglobulins. Its cause is the defect appears to exist on chromosome 14q13.1. Its signs and symptoms is infants have failure to thrive, recurrent or chronic pulmonary infections, oral or cutaneous candidiasis, chronic diarrhea, recurrent skin infections, gram-negative sepsis, urinary tract infections, and severe varicella. Its immunologic manifestations is characterized by lymphopenia, neutropenia, and eosinophilia. In addition, there is a lack of lymphoid tissue and irregular thymus architecture. Next. Severe combined immunodeficiency. Its cause is by the inappropriate development of progenitor cells into lymphocyte precursors. Its signs and symptoms is that as severe combined immunodeficiency first manifests itself as a series of crippling infections that begin during the first 6 months of life. It is dominated by bacterial, viral, and fungal infections of the respiratory and intestinal systems and skin. And its immunologic manifestations is that the thymus and other lymphoid organs are severely hypoplastic. Next. For the chronic mucocutaneous candidiasis, it results from a primary defect in cell-mediated immunity. T cells are unable to identify the candida antigen only, and its signs and symptoms that patients usually live to adulthood. They also manifest signs of candida infection of the mucous membrane, scalp, skin, and nails. Its immunologic manifestations that patients demonstrate normal skin reactions to testing with all antigens except candida. Next. For B cell and antibody deficiency orders, the first is Bruton's X-linked agamaglobulinemia. This is a classic example of an X-linked agaglobulinemia, which means that a disease-causing variant in the Bruton's tyrosine kinase or BTK gene causes B cell production to be stopped at the pre-B cell level. Its signs and symptoms are that patients are infected with high-grade extracellular pyogenic species like streptococci repeatedly, which means that this disorder is characterized by sinopulmonary and central nervous system infectious episodes and severe septicemia. Immunologic manifestations are serum concentrations of IgG, IgA, and IgM are notably below the appropriate level for the patient's age. Next. Common variable immunodeficiency. It is a form of primary acquired agamaglobulinemia that affects both men and women. Its cause is the abnormalities of B cell maturation, antibody production, antibody secretion, or T cell regulation. Its signs and symptoms is that it manifests in the second or third decade of life. Frequent sinopulmonary infections, diarrhea, endocrine and autoimmune disorders, and malabsorption. Example is the vitamin B12. And immunologic manifestations it is decreased concentration of immunoglobulins and near absence of serum and secretory IgA. Next. For the immunoglobulin subclass deficiency, first we have selective immunoglobulin A deficiency. Next. Its cause is IgA deficiency, and signs and symptoms. Infections occur predominantly in the respiratory, GI, and urogenital tracts. Immunologic manifestations is up to 44% of patients with IgA deficiency demonstrate antibodies to IgA. Next. Next. Immunodeficiency with elevated immunoglobulin M or the hyper-IgM. Its cause is the abnormal gene in the X-linked type has been localized to XQ24 to XQ27. And signs and symptoms, it occurs in the first or second year of life with recurrent pyogenic infections including otitis media, sinusitis, pneumonia, and tonsillitis. Immunologic manifestations is characterized by extremely low concentrations of IgG and IgA, also most frequently greatly elevated concentrations of polyclonal IgM. Next is the transient hypogammaglobulinemia of infancy. Patients with this type of deficiency will synthesize antibodies to A and B erythrocyte antigens as well as diphtheria and tetanus toxoids, unlike those with Bruton's X-linked agammaglobulinemia or CVID. It can next X-linked lymphoproliferative disease or the Duncan's disease. It's caused by a recessive trait, and defective gene has been localized to the XQ26 to XQ27 region. Its signs and symptoms characterized by an inadequate immune reaction to infection with Epstein-Barr virus. Immunologic manifestations mark impairment in the production of antibodies to the EBV nucleus has been noted in affected patients. Next. For partial combined immunodeficiency disorders, first we have Wiskott-Aldrich syndrome or the immunodeficiency with thrombocytopenia and eczema. It's caused by a mutation of the gene encoding Wiskott-Aldrich syndrome protein or the WASP, which is essential for actin polymerization in blood cells. Its signs and symptoms, characterized by the triad of thrombocytopenic purpura, increased susceptibility to infection, and eczema or atopic dermatitis. Immunologic manifestations, there is a tendency toward the development of autoimmune disease. Next. Hereditary ataxia, telangiectasia. Cause is results from the coexistence of a T cell deficiency with a defect in DNA repair, which may lead to chromosomal instability that is severe and non-random. In more than half of the patients, chromosomes 7 and 14 are the sites of chromosomal breakage. Signs and symptoms characterized by ataxia and chorioatetosis in infancy. Ataxia means it affects the patient's coordination, balance, and speech, while chorioatetosis is a movement disorder. During infancy, numerous telangiectasias occur on exposed oculocutaneous surfaces, as seen in the picture. And immunologic manifestations is the thymus is hypoplastic or dysplastic. Next. Hyperimmunoglobulinemia E syndrome. Its cause is presumed autosomal dominant pattern of inheritance. Signs and symptoms, recurrent severe staphylococcal abscesses. Immunologic manifestations, elevated levels of serum IgE and IgD, usually normal concentrations of IgG, IgA, and IgM are present. Next. T-cell activation defects. The following are the patient's experiences when they have defective activation of the T-cell. First is defective surface expression of the CD3 TCR complex caused by mutation in the gene encoding the CD3 gamma subunit. Next is defective signal transduction from the TCR to intracellular metabolic pathways. And last is the pre-translational defect in IL-2 or the other cytokine production.
Next, please. So if there is a primary immunodeficiency disorder, kindly please back it to the first slide. if there is a primary immunodeficiency disorder, of course, there is a secondary immunodeficiency disorder. So what is secondary immunodeficiency disorder? A secondary immunodeficiency can result from a disease process that causes a defect in normal immune function. This leads to a temporary or permanent impairment of one or multiple components of immunity in the host. Much more common than primary deficiency. So it is much more common than the primary, even though it's the primary immunodeficiency disorder. So it has increased susceptible to infections as seen in PIDI. So again, secondary immunodeficiency disorder is much more common than the primary immunodeficiency disorder, and it is susceptible to, or it is much prone to infection. So next slide, please. So the major causes of secondary immunodeficiency disorder, first, it is the immunosuppressive agents. So immunosuppressive agents in varying degrees, immunosuppressive agents have been demonstrated to affect every component of the immune system or the immune response. That's why it is a major cause of secondary immunodeficiency disorder. The next is the burns. Another major cause of secondary immunodeficiency disorder is burns. In burn patients, septicemia is a common complication in those who survive the initial period of hemodynamic shock. So we all know what is hemodynamic shock. The next slide, please. So another factor in secondary immunodeficiency disorder is its classification. So what are the classification of secondary immunodeficiency disorder? So next slide. First, okay, the first classification of secondary immunodeficiency disorder is the hematologic lymphoproliferative disorder. So under this hematologic lymphoproliferative disorder are this kind of disorders or diseases. First is the Hodgkin's and lymphoma, leukemia, myeloma, macroglobulinemia, agranulocytosis, and aplastic anemia sickle cell disease. So I will not further discuss these diseases, but to note, these diseases or disorders are under secondary immunodeficiency disorder classification of hematologic lymphoproliferative disorders. So another classification is, next slide please. So another classification includes other systematic processes and metabolic disorders, which includes nephrotic syndrome, protein-losing enteropathy, diabetes mellitus, malnutrition, hepatic disease, uremia, and aging. So I will not also further discuss, but please take note that other systematic processes and metabolic disorders are which include this kind of syndrome, diseases, or disorders. Next is viral infection, one of the classification of secondary immunodeficiency. And under viral infection, we have AIDS. Under surgical procedure and trauma, so we all know that after surgical procedure, our tissue are damaged and have caused trauma to our tissues and body organs like that. And under surgical procedures and trauma, we have splenectomy and burns. And lastly, for the classification of secondary immunodeficiency disorders, we have immunosuppressive agents. So under these agents, please back to the first slide. So under the immunosuppressive agents, we have antimetabolites, corticosteroids, and radiation. So again, secondary immunodeficiency is a disease process that causes a defect in normal immune function, which is, again, it is more common than primary immunodeficiency disorders, and it is prone or susceptible to infections. So another topic that I will discuss is immune-mediated disease. So next slide, please. So another topic is immune-mediated disease. Immune-mediated disease, it is the disorders of the immune response in normal, but the reactive is heightened, prolonged, or inappropriate. So in simple way of saying what is immune-mediated disease is OA. It is overreacting response of your immune system. So first is the allergic reaction. So we are very familiar with allergic reaction. So it is characterized by a mediated response on exposure to an offending antigen and the release of mediators. For example, the release of histamine, leukotrienes, and prostaglandins. So allergic reaction is also associated with IgE, but not all IgE is allergic mediated. So we have to note that others are by CA3 and C5, C3, C3A and C5A. Anaphylactosins, which are capable of producing similar reactions. So another associated immunoglobulins are those. So next slide, please. So let's go to the type of immune-mediated disease. So first is the allergic hypersensitivity. So again, recall, immune-mediated disease is the overreacting of your immune system. So this is the type of the overreacting immune system. So again, the allergic hypersensitivity, which is we are very familiar of. So it is caused by foods, drugs, aeroallergens like dust, pollens, and molds. So I think most of the people have allergic hypersensitivity. So next, the second one is the contact hypersensitivity, which is causes by poison, IV, nickel, and cosmetics. So we are very familiar if there is a allergic reaction or hypersensitivity that is associated with cosmetics. The next is autoimmune diseases. These autoimmune diseases include systemic lupus erythematosus, rheumatoid arthritis, vasculitis syndrome, hemolytic anemia is also a part of autoimmune disease, idiopathic thrombocytopenia. And when we say idiopathic, we don't know the real origin or there is unknown origin. And next is pernicious anemia, good pasture syndrome, myasthenia gravis, which is yung isang eye niya is hindi pantay dun sa kabilang eye. Next is Graves' disease, which is yung eye is sobrang nanlalaki. So that's all for the autoimmune diseases. I will not further discuss each of these diseases because most of the diseases we are very familiar of. But autoimmune diseases, ito yung disease which is your immune system do not recognize your WBCs or your cells. Ang nire-recognize niya lang is foreign body. So to make it simple, autoimmune disease, hindi niya kilala yung mga WBCs mo, your neutrophils, eosinophils. Ang kilala niya lang is foreign bodies. So the result of this autoimmune disease, kinakain niya pati yung good cells mo or yung mga neutrophils mo. So that is autoimmune disease. So to sum up my report, we have secondary immunodeficiency and immune-mediated disease. So that's all for my report, and may I call on Ms. Sampang for the autoimmune lymphoproliferative disorder. Hello, Ms. Sampang. Nakamute ka? Thank you.
Okay, I'm sorry for the delay. Hindi ko alam na kamute pala ako. And now I'm going to discuss to you about the autoimmune lymphoproliferative disorder. Autoimmune lymphoproliferative syndrome, or also known as ALPS, can have a variety of patterns of signs and symptoms. Most commonly, lymphoproliferation becomes apparent during childhood. Why? Because autoimmune lymphoproliferative syndrome is an inherited syndrome or disorder in which the body cannot properly regulate the number of immune system cells or the lymphocytes. It causes an abnormally large number of lymphocytes called lymphoproliferation. And people with classic form of ALPS generally have a near normal lifespan, but have a great increased risk of developing cancer of the immune system called lymphoma, compared with the general population. And now, this is the accumulation of excess lymphocytes results in hepatomegaly. Hepatomegaly is the enlargement of the liver. Splenomegaly, which is the enlargement of the spleen. And the lymphadenopathy, which is the enlargement of the lymph nodes. Splenomegaly are the enlargement of spleen that can be severe in children. Next, patients with autoimmune lymphoproliferative disorder is also susceptible to autoimmune disorder that targets the blood cells and the organs. Autoimmune disorder occurs when the immune system malfunctions and attacks the own body's tissues and organs. Autoimmune disorder typically develop several years later. And this is an example of autoimmune disorder that targets the blood cells. When autoimmune disorder attacks the red blood cells, it is called the autoimmune hemolytic anemia. It occurs when the body destroys its own red blood cells, causing weakness and fatigue. And when it attacks our white blood cells, it is called the autoimmune neutropenia. Neutropenia occurs when the body destroys infection-fighting cells called neutrophils. A decrease in neutrophils increases the risk of infection, which can lead to symptoms such as mouth ulcers and slow wound healing. And when ALPS attacks platelets, it is called the autoimmune thrombocytopenia. It occurs when the body attacks and destroys blood components, called platelets. When platelet levels are low, the blood does not clot well, and bleeding cannot be controlled following more minor injuries. Thrombocytopenia can lead to nosebleeds, gum bleeds, and bruises. The most frequently combined syndrome of hemolytic anemia and thrombocytopenia is called the Evans syndrome. Evans syndrome is a rare disorder in which the body's immune system produces antibodies that mistakenly destroys red blood cells, platelets, and sometimes certain white blood cells called as neutrophils. This leads to abnormally low levels of these blood cells in the body called cytopenia. And now we'll tackle the organs, the autoimmune disorder that affects other organs in tissues. When it affects the kidneys, it is called glomerulonephritis. When it attacks the liver, it is autoimmune hepatitis. When it attacks the eyes, it is called uveitis. Uveitis is the swelling of the middle layer of the eye, which is called the uvea. It occurs from both infection and non-infection causes. The uvea supplies the blood to the retina. The retina is the light-sensitive part of the eye that focuses the images that you see and sends them to the brain. It's normally red due to its blood supply from the uvea. So kapag meron kang gantong disorder, it can cause blindness. And For the nerves, it is called the Guillain-Barré syndrome. Guillain-Barré syndrome is a rare disorder in which our body's immune system attacks our nerves. Yung nerves naman yung inaatake niya. Weaknesses and tingling of your extremities are usually the first symptoms. This sensation can quickly spread, eventually paralyzing the whole body. So, kapag na-attack na ng ALPS yung nerves natin, ang endpoint natin magiging paralyzed na tayo. Hindi na tayo makakagalaw. Kasi 'di ba yung nerves, siya yung nagsisend ng signal sa ating mga muscles para mag-contract, para gumalaw. So kapag na-atake na ng ALPS yung nerves natin, wala nang magsisend ng signal sa mga muscles natin. So magiging lantang gulay na lang tayo. Hindi na tayo makakagalaw. And lastly, for the skin, it is also called the urticaria. Urticaria, also known as hives, is an outbreak of swollen, pale red lumps or flakes on the skin that appears suddenly, either as a result of the body's reaction to certain allergens or for unknown reason. Pag nga, di ba, sinabi natin na autoimmune diseases, yung mga white blood cells natin, inaatake niya yung sarili niyang white blood cells, red blood cells, or platelets. So wala nang makakapag-prevent sa mga foreign bodies na mag-proliferate sa ating katawan. And then, what is the causes of proliferation? The essential role of FAS plays in maintaining lymphocyte hemostasis and peripheral immune tolerance to prevent autoimmunity. Etong DNA na yan yung diyan may problema yung katawan natin. The mutation in FAS gene causes ALPS in approximately 75% of affected individuals. These mutations are associated with the classic form of disorder. The FAS gene provides instruction for making a protein involved in a cell signaling that results in the self-destruction of cells. Katulad nga nung sinabi natin kanina na pag-usapan natin yung mga enlargement of our organs, of our kidneys, of our spleen, ang ibig sabihin doon, hindi very large accumulation of white blood cells doon sa ating organs, sa ating specific organs. Kaya ang problema dito, doon sa FAS gene na yan, siya yung nagsasabi, di ba ang white blood cells natin, kapag tapos na yung trabaho niya, kapag wala na siyang silbi, kailangan mamatay siya. Dahil may problema tayo sa FAS gene, hindi dumadating yung signal sa ating mga neutrophils na kailangan mamatay ka na kasi wala ka ng silbi. So, ibig sabihin, pag-gala-gala pa rin siya dun sa organ natin, tapos nag-accumulate, nadadagdagan yung mga white blood cells natin, pero hindi siya nababawasan. Kaya lumalaki yung mga organs natin. When the immune system is turned on or activated to fight an infection, large number of lymphocytes are produced. Katulad nga nung, kaya hindi siya, di ba sabi nga natin kanina, inaatake niya yung sarili niyang kain. So, kapag a large number of lymphocytes are produced when there is an infection. So, ibig sabihin, kahit hindi siya infection, kahit sarili siyang neutrophils ng katawan natin, kahit sarili siyang red blood cells of platelets sa sarili natin, inaatake niya. Pero hindi siya nababawasan. Nadadagdagan lang siya na nagdadagdagan. So, palaki lang ng palaki yung organ natin. FAS gene mutations lead to an abnormal protein that interferes apoptosis. As a result, excess lymphocytes accumulate in the body's tissues and organs and often begin attacking them, leading to autoimmune disorder. Interference with apoptosis allows cells to multiply without control, leading to the lymphomas that often occurs in people with this type of disorder. And that wraps up our presentation for today. Thank you for listening, and thank you. Hello.